The following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. This educational activity is supported by independent educational grants from Astellas, Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc.
Good morning, everyone. While they're getting their slides pulled up, just want to thank you all for being here this morning and honored to be part of the panel again. So thank you, gentlemen, for having me. I'm Mary Dunn. I'm a nurse practitioner at UNC in Chapel Hill, and I tell people I have the best job in the world because I have a multidisciplinary role where half of what I do is in urology and half GU medical oncology. So I get the whole gamut of things minus radiation. So no one wants me talking about radiation, so you won't hear a lot about that today. But happy to be talking to you all this morning about advanced prostate cancer, and going to try and save as much time as I can for my partners on the stage because their space has kind of exploded a little bit more than prostate cancer. But since prostate cancer is so common and so many urology practices are now treating folks with advanced prostate cancer and maybe don't have access to medical oncology, I think it's important that we hit the highlights of treating advanced prostate cancer. All right, so this is just an outline of what we're going to be talking about today. I won't read it to you word for word because we have a lot of content to get through. So this is kind of I borrow this slide from my partner, Dr. Wayne, the natural history of prostate cancer clinical states model. So this is if someone goes from being diagnosed with localized prostate cancer all the way to metastatic castrate-resistant disease, kind of what that time frame looks like. We, of course, hope people don't get to the end of this screen here. But how we're going to define castrate-resistant disease is when the testosterone is less than 50. And how do we know when people are progressing once they get to this point? So we look at the rise in PSA and also radiographic progression, which we define as 2 or more new lesions on imaging. And we'll talk about some imaging modalities. All right, so there's different definitions of advanced prostate cancer, and the one I'm really going to focus on today is distant or metastatic disease. Of course, there is biochemical recurrence, which there are some new data in that space that I have one slide about locally recurrent disease, but I really want to focus on distant disease because that's kind of where the bread and butter is in the context of chemotherapy and systemic treatments. So what are some diagnostics that we use in advanced prostate cancer? So kind of the tried and true CT, abdomen, pelvis, and chest, looking for lymph nodes and visceral disease, radiographic bone scan to eval for lesions of the axial skeleton, bone density scan, so that's our DEXA scan that we like to get on folks to check for osteopenia or osteoporosis, either before starting ADT or once they have started ADT. And then prostate MRI for utility in men with advanced prostate cancer. Sometimes our radiation oncology colleagues like us to get this for folks who, let's say they have de novo metastatic disease and they have significant lower urinary tract symptoms, and they think that palliative prostate radiation could be potentially beneficial, then a prostate MRI might come into play in this patient population. And then everyone has questions about when are we using PSMA PET and who are we using PSMA PET on and why and how and are we getting it paid for? There was a whole instructional course about this yesterday that I hope all of you attended because we could have a 2-hour talk about how we're using PSMA PET. But it targets PSMA, which is a protein expressed by prostate cancer cells, and there's a couple of different tracers that are used. The indications now are for risk stratifying high risk or very high risk localized prostate cancer upon diagnosis, patients who have a biochemical recurrence after definitive treatment for their prostate cancer, workup for progression in the proper patient. If there's something that's equivocal, let's say on conventional imaging like CT and bone scan, and then prior to giving any PSMA targeted radioligand therapy to see if they qualify for that therapy. So we know that PSMA PET is a good test. So for nodal staging and for bone staging, it has high sensitivity and specificity when we compare it to things like MRI, CT scan, and also bone scan. But it can be a little tricky with equivocal results. So in talking about advanced prostate cancer, when do we start androgen deprivation therapy? So the number one reason to start ADT would be for men who have symptomatic metastatic disease, right? These are the folks who present to the emergency room with de novo metastatic disease who are symptomatic, bony mets, urinary retention. Those folks need to get started on ADT right away. And then for asymptomatic metastatic disease, and then the other folks I didn't highlight because we're not really going to focus on biochemical recurrence today. So what's the goal of androgen deprivation? You all know this, right? The goal is castration. I tell my patients all the time because they ask me, once they do progress eventually and we have to add secondary treatments, can I please come off this awful hormone therapy because my hot flashes are interfering with my quality of life? The way I describe it to patients is that their ADT is like the base of the pyramid. So if you think about treating prostate cancer, I like to think of it as a pyramid. The ADT is the base, and then we add things to that. And if we take away the base of the pyramid, if we stop the ADT, then the whole plan crumbles, right? The whole pyramid crumbles, because the goal of treating metastatic prostate cancer is to keep that testosterone as low as possible. And there's several ways of going about this. So one is surgical, which, as all of you in this room know, we don't do that quite as much as we used to in the context of medical management of ADT. So we do that with either LHRH agonist or LHRH antagonists. I'm not going to go through the hormonal regulation of the prostate gland. This is more of an FYI. I know you all know these things. So I don't know if any or all of you are doing bilateral orchiectomy, but again, like I said, we don't really do this anymore. I did have a patient recently ask for this, believe it or not. So he is someone who every time he gets his Leuprolide, he gets horrible testicular pain. So he has actually started to decline his ADT and doesn't want to try Relugolix and said he would be fine having a bilateral orchiectomy. So that's the first time I've heard that in quite a long time. So as far as medical management, I'm sure you are familiar with using these medications. So the gonadotropin-releasing agonists stimulate LH and FSH from the pituitary gland to the testicles and usually reach a castrate level of testosterone within about 4 weeks. The most common agent we use is Leuprolide, and that comes in different doses from 1 month all the way to 6 months, and that just depends on your formulary. We do a lot of 3 and 6 month doses at my institution. The GnRH antagonist directly inhibits the pituitary LH and FSH release. So this is degarelix. This one doesn't cause the surge in androgens like the agonists can. So we typically use this in folks who present with de novo metastatic disease, especially those who might be symptomatic, to get a quick castration. So this can lead to castrate levels of testosterone within 3 days of administration, and it avoids the androgen surge, which in patients who have bone mets can cause pain. And then a typical pattern we follow is we give this as a loading dose, and then 4 weeks later, we start folks on an agonist. And the reason why we do that is because the agonists are given in longer intervals, whereas the degarelix is given as a monthly injection after the loading dose. And then we do have an oral option. So a GnRH antagonist called Relugolix. This is given as a one-time loading dose and then a daily dose. It's an oral agent. This was based on phase 3 data from the HERO trial comparing it to Leuprolide. Some things that are important about this is, number one, it's a pill folks have to take and not an injection, and that can be appealing for some patients who are needle averse, but it is another pill that folks have to take. This sustains testosterone suppression. It was 97% versus 88% in Leuprolide. The mean testosterone level at day 4 in the HERO trial was 38 versus 625. So you see how quickly it works. And then mean testosterone recovery was much faster once patients stopped their Relugolix versus stopping their Leuprolide. So that's another benefit. And Relugolix has a favorable cardiovascular side effect profile. So this is also an attractive option for patients who have significant cardiovascular disease. All right, this is not something we really do anymore. Non-steroidal anti-androgens as like the sole androgen deprivation therapy. This is just kind of a shout out to history. I'm a big fan of history, but we don't really do this anymore. So how long do we give hormone therapy? So my little box of metastatic disease, uh, the vast majority of the time, this is going to be continuous, right? So these are people who have are going to be living with this for the rest of their life. But there is some data to support the use of intermittent hormone therapy in men who have advanced or metastatic disease based on a SWOG trial. This is something that we utilize in practice if men have low burden of metastatic disease and have an extraordinary PSA response. In other words, if their PSA plummets and remains low or undetectable for a sustained period of time, and people are asking for a treatment break, then this is something we can consider. The good part about stopping hormone therapy is that you can always restart it and restart it quickly, but sometimes there are patients who want a break. Frankly, the vast majority of men do not want to be off treatment for their cancer because of all the anxiety that comes along with that. But just know that this can be appropriate in a certain patient. So what are the side effects of hormone therapy? Well, a lot of things. And this is something that I think we all need to be talking to our patients about. You get that patient in your clinic who has advanced prostate cancer. There's a lot to talk about during that visit, right? People are scared. You're talking to them about a cancer that we don't have curative treatment for. There's lots of options in this space now. There's lots of toxicities and side effects. There's a ton of follow-up that comes along with this. But I think ensuring that we talk about the potential side effects of hormone therapy so that they're not shocked when they, have their night sweats 5 times a night, or they gained a bunch of abdominal weight and their sex drive goes away. So I think education is key, even in the context of a busy practice. So I think this is where our physician partners can really partner with us as APPs to have advanced practice providers seeing these patients as well for toxicity and side effect management. How do we manage these things? Well, not well. I'm going to be frank. There's a lot of side effects and not a lot of great management for these toxicities, and that's something that, as an APP, I find it incredibly frustrating. But for hot flashes, they all get hot flashes, right? And to a varying degree. The data for pharmacologic management is lacking, so sometimes we just try some things, paroxetine, sometimes clonidine, sometimes we'll add in a little spice of gabapentin, because what don't we use gabapentin for these days? But we have to be mindful with gabapentin because of the cognitive side effects. The thing with all of these side effects I'm going to go through briefly is physical activity is something that we know can help mitigate a lot of these side effects to an extent. And patients look at me when I say, how much exercise are you getting? They look at me like I have 12 spinning heads because they have castrate testosterone and they, barely have energy to do the things they want to do, much less, take a 30-minute walk every day like I'm asking them to. But we know that it can help with a lot of things. Some men do identify triggers for their hot flashes like caffeine and spicy foods. So, you're taking away things that bring them joy. And there's a little bit of data about acupuncture. It's certainly not hurtful. The cognitive decline is real. I've had several patients in the past couple of months who have had significant complaints with their cognitive decline. They say, Mary, I just do not feel sharp. I cannot focus. I cannot remember things. This is a significant thing, especially for men who come in and they're rather high functioning. When they start to realize that they're having some of these cognitive side effects, it can be very, very distressing. Again, physical activity. I try and teach patients some mindfulness-based activities, and we do have a comprehensive cancer program at UNC that incorporates some of that into practice when we send referrals. Mental stimulation. There's a little bit of data showing that things like crossword puzzles and Sudoku, which I can't do, so I admire anyone who can do those number types of things. But just like mental stimulation, reading, things like that can sometimes help with the cognitive effects, but it can be quite frustrating. And then fatigue. Who's tired this morning? Me, but it's not because I did anything fun last night, I swear, even though I'm in Vegas. But physical activity, we talk about sleep hygiene and mindfulness. And then I always like to point out that when folks are fatigued, which all of them are, making sure we're also addressing contributing factors. So things like anemia, right? If they're anemic from the chemotherapy that we're giving them, checking their thyroid, treating things that are treatable that could help with the fatigue as well. And then metabolic syndrome, partnering with our primary care colleagues to help us manage things like glucose and hyperlipidemia, and again, physical activity and healthy, well-balanced diet. Everyone in this room knows how to treat sexual dysfunction, so I'm not going to hit on that. But the one thing I do want to drive home here is that Men with advanced prostate cancer or metastatic prostate cancer, this is just as important to them as men who have local prostate cancer, right? So just because men are living with an advanced disease doesn't mean that this is not something that's a priority for them. Sometimes they don't know how to bring it up if we don't bring it up. So I think that's an important part of what we need to be doing. And then, of course, smoking cessation, because of the cardiovascular morbidity that comes along with that, in addition to living in a castrate state. I always check on the emotional aspect of all of this. So not only living with a terminal cancer, but also the emotional lability that comes with not having any testosterone can be really challenging for our patients and also for their partners as well. So getting folks the mental health resources that they need, referring them to support groups and our psychiatry colleagues is, I think, a really important part of what we do in taking care of patients who have advanced disease. And there's lots of resources out there. So how do we take care of our bones? Well, as we know, ADT can cause things like osteopenia and osteoporosis. So again, making sure we're getting those DEXA scans prior to starting treatment, and then we recommend getting them every 2 years. Making sure your patients are on calcium and vitamin D and getting good weight-bearing exercise. For men who have metastatic castrate-resistant disease with bone mets, we like to treat them to prevent skeletal-related events. And then for men who are on long-term ADT with osteoporosis, that's when we treat them with bone protective agents. So we have zoledronic acid and denosumab. You can see kind of their different mechanisms of actions here and what they're indicated for. But just be mindful that this is one thing that definitely needs to be addressed and checked off the box to ensure that your patients are getting the proper bone health along the way. So I love a timeline. I'm a sucker for a timeline. If y'all have heard me talk before, I'm a very visual person, and a timeline is great. I've been doing this work for 15 years, and this timeline used to fit like on 2 little bubbles. So now I'm very pleased to show that it fits on 2 slides. So we've come a long way in treating advanced prostate cancer, and this just goes through the timeline of when different drugs were approved, and they're color coordinated because that's who I am as a person, based on their mechanism of action. So I won't go through this explicitly, but I just wanted to make sure you all can see like kind of how far we've come in this space. We've got a long way to go, but we're making strides. These are the options. I can fill up a whole slide, and now it's like a little smaller, right? So we have chemotherapies, we have those androgen receptor inhibitors, PARP inhibitors for the right patients, immunotherapies, radiotherapies. Oh, I didn't mean to do that. Sorry. So I know some of you were taking pictures, but I accidentally hit the button. Sorry about that. I think the slides are available. So, of course, as soon as I turned in these slides, the NCCN updated their guidelines from January of 2025 to February of 2025. So that was really helpful for me turning in my slides, but there's not too many changes. So these are the NCCN guidelines. They are incredibly helpful, but also a little bit overwhelming once we kind of get down the path here. But it really does outline really nicely like pathways to take for your patients when they have advanced disease. So when we're thinking about metastatic castrate-sensitive high volume disease, and I'll go through each of these, but just wanted you to have the NCCN guidelines for reference. So when we're thinking about metastatic castrate-sensitive prostate cancer, so patients who present with metastatic disease, I'm a big fan of history. I like to give a shout out to history. This was huge, right? The CHARTED trial when docetaxel came out, right? This was almost unprecedented in oncology that the addition of a single agent chemotherapy had this significant effect on outcomes. So this increased survival when adding it to leuprolide by nearly 14 months, which was extraordinary. So we love to give a shout out to docetaxel. However, there are other options for men in this space. So we don't use single agent docetaxel anymore because we have other options. So in addition to ADT, which again always stays, so our patients are always on their baseline ADT, we can consider things like abiraterone and prednisone. Abiraterone is one of the androgen receptor inhibitors. It's an oral medication. It inhibits CYP17. This one is can be a little bit tricky to get patients on if they have uncontrolled hypertension, something that needs to be under control, and also folks who have difficulty getting to you or getting to a lab, because for the first 3 months, they have to have their potassium and their hepatic function checked every 2 weeks for the first 3 months, because it's within that time frame that they might become hypokalemic or have hepatotoxicity. So that's a key takeaway here, is that folks have to be able to have their lab checked. So that's one option for men in this space. Another option for men in this space is apalutamide. So this is an AR that binds directly to the ligand binding domain of the AR. Also an oral option for men, given once a day. The other is Enza. So you're going to see these drugs sprinkled in. They have multiple indications for men with advanced prostate cancer. Enzalutamide is also an oral anti-androgen approved in this space based on the ARCHES and ENZAMET trial, the data that you can see here. And now we have triplets. It was like a birth announcement almost when the data came out for triplet therapy. So what is triplet therapy? It's our baseline ADT plus 2 other medications. So this has been a little bit of a game changer in medical oncology, where we are doing androgen deprivation therapy plus chemotherapy plus one of the androgen receptor inhibitors. So while this is exciting and the data were exciting, as you know, once you add more medications, you increase the risk of toxicity, right? So in the PEACE trial, this was docetaxel plus abiraterone, and men get 6 cycles of docetaxel. So that's given every 3 weeks, and then they continue their ABI once the docetaxel is finished. So this was exciting data from the PEACE trial. And then from the ARISONS trial, this was docetaxel plus darolutamide. So another triplet option, another birth announcement option. We talk about triplets all the time in clinic now. So this is the data from the ARISONS trial. Again, the docetaxel is given every for 6 cycles every 3 weeks. The darolutamide is 600 milligrams twice a day. So that twice daily dosing might be a little tricky for some patients who have trouble remembering to take their medications. So just a little something to remember if you're considering darolutamide for your patients. And this is a chart because I like to have things concise. And again, you'll have reference to these slides. So we have options. So what happens over time? So over time, men with advanced prostate cancer, eventually what we're doing is not going to work well anymore, right? I always tell my patients the cancer just kind of outsmarts what we're doing, unfortunately. So these are the NCCN guidelines for non-metastatic castrate-resistant prostate cancer. So these are men, let's say, who had localized prostate cancer treated, had a biochemical recurrence, or on hormone therapy, and their PSAs are rising, but they have castrate testosterone and their imaging is negative. What do we do with these folks? Because everyone gets a little anxious about that PSA, right? We put so much emphasis on the PSA that sometimes even just a little blip on the radar can cause a lot of anxiety for our patients. So for patients who have a shorter doubling time, PSA doubling time of less than 10 months, then we can consider adding another systemic therapy. For men who have longer PSA doubling time, we prefer to just keep them on their ADT until they have radiographic progression or their PSA doubling time is faster. So what are some options in this space for patients who it's appropriate? You're going to see our androgen receptor friends like pop in and out of all of these spaces, right? So from the PROSPER trial, we know that enzalutamide is an option for folks in this space. The one thing I did want to point out with enzalutamide is there is a seizure warning here. It's exceedingly rare, but we do steer away from this drug for men who have a history of seizures. And then apalutamide, so the data for this space came from the Spartan trial. Again, lots of stuff to get through, so you'll have access to these slides. And darolutamide. So there are three options in this space for men who have non-metastatic castrate-resistant prostate cancer with rising PSAs and a high PSA doubling time. One thing I did want to point out with the darolutamide is unlike apalutamide and Enza, which have higher risk of falls and things like seizures and the hypertension, that we all become cardiologists, right, when we're managing these medications with the hypertension, is that darolutamide does not carry those particular side effects, so could be a good option for folks who are concerned about those potential side effects. And this is just the table that compares those options. All right, does this give anyone else heartburn? No, just me? All right, I've got some antacids up here if anyone needs it. I mean, this is bananas, right? Like, this didn't used to be like this. I have old lady glasses now. I have bifocals, and I still can barely read the words on the slide. But this is exciting. So while it can be a little bit daunting and overwhelming, like, it's so exciting to have all of these options in this space for our patients. But there is a method to the madness, right? Like, that's why there's so many boxes. So knowing what your patients have previously received, knowing what their comorbidities are, what their previous toxicities from their previous treatments, et cetera, really does kind of help like play out how we're going to treat the patients with which medications. But while it can be a little bit daunting, it's also pretty exciting. So like I said, these are things we have to consider. We're fortunate enough to have a clinical pharmacist embedded into our clinic that helps with these drug interactions. So some of these androgen receptor medications have a ton of drug-drug interactions. And of course, our patients are on a lot of other medications. So having a clinical pharmacist at our disposal has been invaluable. She is absolute delight of a resource. So just being really mindful of that. Sometimes we have to talk to primary care about, can we change this statin and what can we do with this medication in order to make sure that we're not causing toxicity from drug-drug interactions. So this, for men with metastatic castrate-resistant prostate cancer, this is kind of what we just used to do, right? Docetaxel chemotherapy. But if men have already seen docetaxel chemotherapy in prior lines, and this is not first line anymore, but this was approved in 2004, so a long time ago. And for in this space, we try and get 10 cycles in. So that's every 3 weeks for 10 cycles, and we do give it with prednisone. With cabazitaxel, that's the other chemotherapy that's FDA approved in this space. Men must have already received docetaxel as prior line in order to be considered for cabazitaxel. The thing we have to be very mindful about with cabazitaxel is the risk for myelosuppression, specifically neutropenia. So we do give this with growth factor, and we have to be very mindful about our elderly patients getting this because they can have much more trouble with the neutropenia. So making sure people have thermometers at home, they're reporting fevers, et cetera, is critical. And other just general chemotherapy side effects that folks should be familiar with, the fatigue. Please, even though your patients are men, like, they do care that they're going to lose their hair. So educating your patients that they're going to lose their hair, eventually it will come back. But we do have to monitor for electrolyte abnormalities. Sometimes folks have infusion reactions, et cetera. So you're going to see our old friends pop up in this space, in the metastatic castrate-resistant space, because this is where they were initially FDA approved. So abiraterone has been around for a long time because it was approved in this space first. So we were so excited about Abi when it popped up in 2011 because we had something to offer other than chemotherapy. And this is given orally, like we talked about, and we do give this with prednisone, if I didn't mention that before, to help protect those adrenal glands from the potential mineralocorticoid-related side effects as those adrenals are being suppressed potentially by the abiraterone. And then enzalutamide, again, I feel like a broken record, but that's because these drugs are indicated in so many different spaces for our patients, which is why it's so important to take a look at those NCCN guidelines, understand where they fit in for your patient, how to manage the side effects, and what are some of the potential barriers for your patients. We do know that there is cross-resistance between some of the androgen receptor medications that we're using. So what we kind of like to do in practice, this little pearl of wisdom, is if we can, try not to use these back to back to see if we can like trick the cancer into thinking it hasn't seen one of these pathways before because of the concern for cross-resistance, because the mechanism of actions. I'm not hitting this. I don't know why it keeps going. Maybe that's just like a sign from the heavens that I need to talk faster. But anyway, being mindful of cross-resistance, sometimes how we do that is by breaking up the ARs with chemotherapy if people are eligible for chemotherapy. So let's say we do Abi, chemo, Enza, or something like that as an example. The Sipuleucel T is an immunotherapy that we have for metastatic castrate-resistant prostate cancer. It's been around for a long time, since 2010. It's an autologous cellular immunotherapy. It's given every other week for 3 doses. Patients have to go to their local Red Cross, for example, to do pheresis and then come back to the infusion center to get it. A thing about immunotherapy and prostate cancer is there's not going to be an immediate PSA change because this doesn't work on the hormone pathway like the rest of the drugs do. So educating your patients that it takes a while for one to build up an immune response and to not fret if we don't see an immediate PSA response, because we usually don't. So using how patients are doing clinically in addition to their PSA response and eventually their imaging is how we see how folks are doing on this. And then radium-223 is a radiopharmaceutical that's been around since 2013. It's an alpha particle emitting radioactive agent. We try and give 6 doses of this. It's every 4 weeks for patients who have bone disease. It doesn't help treat visceral mets, so that's why it's important to make sure you have updated imaging on your patients to ensure they don't have visceral metastatic disease. Again, PSA is difficult to follow. One of the key side effects here, again, is myelosuppression. So we have to get a CBC before giving this drug to ensure people aren't anemic. And then lutetium. So, of course, as soon as I turn my slides in, this got another FDA approval. So I love science, right? So this was initially approved for patients with metastatic castrate-resistant prostate cancer a couple years ago who had seen at least one androgen receptor inhibitor and chemotherapy. So they have to have a PSMA positive PET. So that's something you have to obtain before seeing if they're even eligible to get lutetium. And we try and get in 6 doses of this. It's every 6 weeks. Side effects are kind of weird ones that we don't usually see with prostate cancer medications, like dry mouth is not usually a thing that we're happy to talk about, but we do with these patients. But just in late March, I don't have a slide for this because, again, I try and be a rule follower and put my slides in on time. The FDA approved the use of lutetium for patients with metastatic castrate-resistant prostate cancer who had one androgen receptor pathway inhibitor and are considered appropriate to delay chemotherapy. So what is appropriate to delay chemotherapy? So people who aren't having a lot of pain. We know that patients who are having pain can benefit heavily from getting chemotherapy. Chemotherapy works really well for patients who are in pain, and it works quickly. And this was based on phase 3 data from the PSMA-4 trial, and it reduced the risk of radiographic progression by 59% compared to changing the androgen receptor medication. So this is now FDA approved in a different space. So we're going to be, I haven't done this yet. It's brand new. So of course there's going to be some growing pains in seeing how this fits now into this already kind of crowded and slightly crazy treatment algorithm. Are folks doing genetic testing for your advanced prostate cancer patients? Or at least referring for genetic counseling? Yeah, this is hugely important for our patients with metastatic prostate cancer, because if folks have a genetic mutation, there are certain medications that are approved for them in this space that are effective. So we recommend germline testing for anyone with high risk, very high risk localized prostate cancer, or anyone with any degree of advanced prostate cancer, whether that's biochemical recurrence or metastatic disease. So we can do this in our clinic or refer them to our genetic counselors for assistance with this. But for folks who have certain medications, so BRCA mutations or ATM mutations, there are PARP inhibitors. So these are oral medications that can be given to these patients, and there's the trials that are listed for you there. And also pembrolizumab, which is a checkpoint inhibitor, can be given to patients with metastatic castrate-resistant prostate cancer who have MSI high disease. So that's also something that needs to be tested for as well. So making sure you're having these conversations. And this is just my chart. All right, so some practical considerations. It's hard for our patients to remember to take their medications sometimes, right? Because they have so many other medications. Making sure that we're evaluating their barriers to care. Can they come every 3 weeks for chemotherapy? Can they get labs locally for their abiraterone? Doing education about why we're doing what we're doing, mechanism of actions, toxicities, and how to manage those. Identifying resources at your institution to support you. You can't be a one-person show. This is truly multidisciplinary care. And then professional education to keep up with the growing landscapes. So future directions, I think we're going to continue to see more combination therapy. You saw how excited I got about the triplet announcement, which was a little bit over the top. I do admit that. How are we going to sequence these things? We really don't have great data on the correct or the right sequencing for the right patient. So I think one day that we will. And then again, continuing genetic testing to look for gene expression, using other agents that are used in other cancers as the research grows there, and immunotherapy that are in trials. There's some vaccine trials that are pretty exciting. And then this is just more of an FYI slide for things that we didn't touch on. So for very high risk and for biochemical recurrence, it's important to know that there are systemic treatments that are being used for these patients as well, that a lot of folks in urology are going to be prescribing. So I think it's important to know about these things, even though they weren't kind of in the array of this particular presentation, if you want to have this slide for your reference. So we know that there's no cure for metastatic prostate cancer and that shared decision-making along the way is important. Trying to encourage your patients to enroll in clinical trials so we can continue to make progress in the future. So one day, maybe that first line on this PowerPoint will go away. Always incorporating best supportive care. So making sure we are managing toxicities, making sure we are getting patients the educational materials that they need, connecting them with other disciplines who can help them with those toxicities, our clinical pharmacist, our cancer patient support program to help with the emotional and psychological aspect of being diagnosed with and living with a cancer that we can't quite yet cure. Talking about advanced care planning, I do think this is our job. I think this is not just for palliative care. I think that we, as their primary oncology team, our patients deserve to hear it from us to talk about what are their goals, right? Like what do they want to be able to do every day? What do they want their end of life, their last years to look like, so that we can make sure that what we're doing from a treatment standpoint is aligning with their goals of care. Don't forget about the caregivers and the partners that come with them to clinic and making sure that they have resources as well. This is really complicated stuff. So leaning on your support system, again, it really has to be true multidisciplinary care in order to do this well. And always let patients know that just because there are multiple treatment options, again, I got very giddy about the slide, but just because there are multiple treatment options for metastatic prostate cancer does not mean they have to exhaust them all. Letting people know it's okay to choose hospice as well, right? This is a terminal cancer, so they don't have to exhaust everything in order to say that they've done their best. So giving people permission to transition from active cancer treatment to hospice is always appropriate as well. Thank you.
We're going to hold questions until the end. So,
good morning, everyone. So I wasn't sure what kind of audience we'd get on a Monday morning after a weekend in Vegas, so I applaud you all for coming out and for whoever's streaming. I'll remind everyone there is a chat function on the AUA2025 app where questions can be answered. And I don't mind, since we're relatively intimate, if you want to ask questions in the middle of my presentation, come right on up. My name is Ed Trabulsi. I'm at Jefferson Einstein in Philadelphia, and I'll be talking about bladder cancer. Works, okay. Isn't it moving? Okay. And here are my disclosures. And I also did steal some slides from colleagues. So in terms of an outline of bladder cancer, I'll go a little bit into some of the epidemiology and the pathology, and then we'll talk about where these different treatments fall into the different disease states. Similar to prostate cancer, bladder cancer definitely has its own disease state sort of model. Bladder cancer is a little bit underrated in the popular press. A lot of people are surprised to hear it's the fourth most common cause of cancer in American men. Upwards of 80,000 plus new cases every year, upwards of 17,000 deaths every year. It's one of those cancers where there's a lot more patients out there living with their cancer than dying from it, which is great. And that's because the majority of patients, when they present, are superficial and what I would consider nuisance cancers rather than threatening cancers. It's also very important to remember it's a disease of older patients, average age of onset or diagnosis, late 60s, even pushing 70. Definitions are important and remain important as new agents come onto the clinical arena because they are approved for very specific subsets or disease states. So we talk about low-risk non-muscle invasive bladder cancer. These are patients that really have a very low risk of progression. All bladder cancers have a high risk of recurrence or coming back, but the ones that we really worry about are the ones that are going to get worse. The high-risk non-muscle invasive bladder cancer, those patients definitely are very high risk of both recurrence and progression. And then the muscle-invasive bladder cancer, those are the ones that really are most threatened. That is a lethal phenotype if we don't treat it aggressively. So I grab this and I share with my patients BCAN. This is a diagram from the BCAN book. That's available, and it's also available on the website, the Bladder Cancer Advocacy Network. It's really nice to kind of show patients, what we're worried about, what we're dealing with, what things could turn into. And I explain to patients the lining of the bladder. The analogy I use, it's like the carpet pad, and the hardwood floor. So the urothelium is the inner mucous membrane that the tumors typically develop from, and typically grow up into the bladder like polyps or raspberries. And we think that's contact time of toxins in the urine with the urothelium as the mechanism. If it starts growing roots down into the carpet pad or the lamina propria, that would be stage T1 disease. And if it hits the hardwood floor, the muscle, that's muscle invasive disease. And so really trying to clarify exactly where they start is very important. And we use this criteria and these different aspects together with the size and the histologic grade of the tumor to get an idea of where they fall on the risk stratification. So things like size of the tumor, which we estimate cystoscopically, but fairly accurately, grade, how it looks under the microscope, whether it's a unifocal or a solitary tumor, or whether there's multiple tumors, that raises our concern. Definitely anything that's invasive, like T1, or a flat tumor, CIS, and then a recurrence pattern. And so this is where we use these different aspects to divide patients into low, intermediate, and high risk. And a simple way that I try to teach our residents is that to be low risk, it's a single tumor, not aggressive and small. If it's high risk, those are the larger tumors, the multifocal tumors, the recurrent tumors, the histologically aggressive looking, the ones that are failing treatment, the ones that are starting to invade into the lamina propria. And then you have the middle, which is a little more fuzzy in terms of how to define them. You could have a low-grade tumor that comes back in 6 or 9 months that would move them from low risk to high risk. You have kind of the unicorn, the low-grade but superficially invasive tumor, the low-grade T1. And then we have some very high-risk features. Those would include things like the variant histologies, micropapillary, microcystic, plasmacytoid, if it's involving the prostatic urethra, and then certainly if it's not responding to treatment. And this is kind of like the New York City subway map, but when we try to develop an algorithm on how to treat non-muscle invasive bladder cancer, you can see at the top that the low-risk patients, surveillance definitely may be an option. They may actually not need to get much treatment because, again, their recurrence risk is lower, not zero, but lower, but more importantly, their progression risk is very, very low. The mainstay of treatment for superficial or non-muscle invasive bladder cancer is intravesical treatment, so treatment in the bladder through a catheter. BCG was the first well-studied immunotherapy for solid tumors. We'll talk about that. Other immunotherapy agents in this space include interferon, which is more for historical knowledge. We don't typically use it very much. And then two of the newer immunotherapy agents, nadofaragene and nogapendican. Don't say that twice. And then non-immune therapy options include chemotherapy. Nowadays, primarily gemcitabine with or without docetaxel. Valrubicin is on the list, again, more for historical information. Another important factor, which is not necessarily universally adopted, is the benefit of giving a single post-op intravesical treatment into the bladder after a biopsy or after a TURBT. And this was a SWOG study looking at giving a single dose of gemcitabine into the bladder right after biopsy. And you can see that the recurrence rates were significantly lower in patients that got a single dose. It sort of makes sense because one of the reasons we think that recurrences are so common is that we liberate tumor cells in the actual process of biopsying them, and they stick around and float around and then land somewhere else, and then it turns into a recurrence. You sort of sterilize the urine. And among the patients who got intravesical gemcitabine, it seems the majority of the benefit was on the low-risk patients. The high-risk patients didn't really see as significant of a reduction of recurrence. So BCG, it remains the gold standard. It's a non-specific immune adjuvant. It causes an inflammatory response with cytokines, and it really is still, until something topples it off the top of the mountain, the best agent to reduce the recurrences and, most importantly, to reduce progression. It's generally well tolerated. Flu-like symptoms, lower urinary tract symptoms. There can be a small subset of patients that can get systemic BCG infection. It's one of the reasons why we typically will wait at least 4 to 6 weeks after their biopsy before we administer it, less likely to get into their system. And there's a growing awareness of the importance of maintenance, giving treatments on a schedule over time as an immune-based therapy to re-stimulate the immune system to keep it active and surveillant against new tumors. We don't quite know all of the different mechanisms of how BCG works, but there does seem to be both a direct cytotoxic effect and then both an innate immunity and an adaptive immunity response. BCG stands for Bacillus calmette-guerin. Calmette and Guerin were two microbiologists in the Louis Pasteur Institute. It's used as a TB vaccine intradermally in the third world, and then I don't know who thought of putting it in people's bladders, but we've been doing it for 50-odd years. It's once a week for 6 weeks. Try to hold it for 2 hours. We tell patients to avoid their coffee or their hydrochlorothiazide until after the treatment. And again, the side effects are generally very well tolerated. You can reduce the dose in patients that are not doing as well. The maintenance therapy is cutting the treatment cycle in half. So instead of 6 weeks, they'll get 3 weeks on different intervals. Looking at the importance of full dose versus reduced dose in maintenance was looked at in a European study. They looked at 1/3 dose BCG versus full dose, and then looked at high risk and intermediate risk patients. And there is a benefit to full dose and maintenance, but in this situation of a BCG shortage, we should definitely prioritize towards the higher risk patients. And this was a consensus statement that AUA came out in 2020, and the important things that I'll highlight, as we saw on the algorithm, BCG is really not needed in the low-risk patients, so we need to be stewards of our BCG supply. We should save it for patients that really are at much higher risk of recurrence and progression. And then in patients that have high-risk disease, we should try to prioritize whenever possible that they would get full strength rather than reduced dose. And then in really extreme circumstances, maintenance therapy really should be abrogated and BCG really preserved for the highest risk patients. So when does a patient fail BCG? We used to use a term BCG refractory, and it was sort of a catch-all of anyone that got BCG and then had tumors. And we really need to be much more precise in our definitions. And this is sort of put upon us by FDA because this schema or the definitions are directly baked into all of the clinical trials that you've been hearing about all weekend. So we really need to be very explicit, and it's incumbent on us to really document accurately, because the payers will be looking for this kind of information on their treatment decision approvals. So the concept of adequate BCG is relatively new. So we can't just say we tried one vial or one treatment and they failed. Adequate BCG typically is required for 2 induction 6-week courses, or an induction plus 1 maintenance. And of those cycles, they really should get at least 5 out of 6 of the initial induction, and at least 2 of the 3 maintenance, or 2 of the 6 of the second induction. If they got less than that, either due to intolerance or noncompliance, then they're typically not going to be considered adequate BCG, but they might be BCG intolerant, that they just can't tolerate it. So if they get adequate BCG and then they get recurrent tumors, how are we going to categorize those patients? And so BCG relapsing is defined as recurrent high-grade non-muscle invasive disease in patients that were at least 6 months disease-free after getting BCG. BCG unresponsive, there's 3 different ways you can land in that definition, is if they have CIS and they have a recurrence within the first 12 months with or without papillary disease, again, after adequate BCG, or if they have high-grade T1 or high-grade TA disease within the first 6 months after adequate BCG, or if they have persistent T1 at their first post-treatment assessment in 3 months. Any one of those 3 categories can be labeled as BCG unresponsive, and the importance of that is that they are then eligible for some of the newer treatments that I will talk about. Then the newest sort of phrase is BCG exposed or BCG experienced, and these are any high-risk recurrence after 12 months of adequate BCG. So when we think about what to offer patients that have a recurrence after BCG, we think about salvage intravesical treatments, and this is either chemotherapy or some of the novel immune agents that are being looked at. We also look at systemic checkpoint inhibition. Certainly, we would want to consider clinical trials in this space, but very importantly, we should not forget the importance of radical cystectomy, that there may be a window of cure, and if we delay with trying to save their bladder with newer agents, we may put the patient at risk. So these are patients that are young, that are healthy, that you have a very direct goals of care discussion. What's our real goal? And if they say cure, then we really should consider radical cystectomy. So the FDA really opened the door to all of the new lines of research in 2018 with their guidance document. And this is where the BCG unresponsive definition and adequate BCG definitions really got baked in. They also specified that a complete response endpoint for CIS with or without papillary disease would be the one they'd be looking for registrational purposes. They also allowed a single-arm trial design, which was novel at the time. Typically for registration, it's a phase 3 randomized trial, but FDA allowed the single arm because there really was no innovation in the space. And so what's a complete response endpoint? That's a negative cystoscopy and cytology. Didn't necessarily mandate a biopsy, but for-cause biopsies absolutely should be done. Patients who have suspicious-looking lesions or a positive cytology, you'd want to biopsy them. And then, as I said, high-risk disease at 3 months should be considered a treatment failure immediately, and on a trial, they'd be removed from the trial, potentially offered a cystectomy. So looking at the NCCN guidelines, we have BCG unresponsive or BCG intolerant. Again, top of the list would be radical cystectomy. Now, not every patient is appropriate or willing for that, but we need to have that discussion. Salvage intravesical chemotherapy, systemic pembrolizumab, and then the 2 newer immune modulating intravesical agents, nadofaragene and nogapentin. So where does immune checkpoint inhibition fit in? Mary mentioned pembrolizumab earlier. It's an anti-PD-1 antibody. This was approved in January 2020 for high-risk BCG unresponsive, non-muscle invasive CIS with or without papillary disease. I'm going to use that terminology over and over again because CIS is the backbone of approval. Papillary alone right now is not on the approval docket, and this was the Keynote 57 trial of 148 patients. They had a complete response rate of 41% with a median duration of response of 16 months. Nadofaragene is the next one that got approved in this space. The brand name is Adstiladrin. This is a replication-deficient recombinant adenovirus, a form of gene therapy delivering interferon alpha-2b. This is indicated again for BCG-unresponsive CIS with or without papillary disease. It's a single intravesical dose, 75 cc's of about 30 billion viral particles, and it's given at 3, 6, and 9-month doses, so not the 6-week schedule, but more every 3 months. This is the original trial that led to approval, and you can see CIS with or without papillary disease. At 3 months, the complete response rate was 53%, leading to the approval. Anktiva, which is much easier to say than nogapendenkin, is the second intravesical immune therapy to be approved recently. This is an IL-15 superagonist. The research name was N803. This is given together with BCG, so it's an adjuvant to BCG to boost the effectiveness of it. It's a fusion protein that promotes proliferation and activation of NK cells and CD8 positive T cells, and importantly, doesn't upregulate the suppressive Treg cells. The QUILT 3032 trial looking at BCG unresponsive CIS with or without papillary disease was reported out with a complete response rate of 71%. Importantly, it did allow a repeat induction. So this is, since it's a BCG backbone treatment, it was 6 weeks, just the way BCG is given. They were allowed to get a second 6-week course of BCG with the Anktiva. But 55% complete response rate at 3 months and 45% at 12 months. So this was FDA approved just about 1 year ago in April 2024. And this is the original paper that led to approval. We were involved in this trial at Jefferson and really very well tolerated. But the FDA guidance document really opened the door, and you can see an amazing amount of innovation in this space. We have device delivery options like the Taurus platform. The Taurus platform is a, for lack of a better word, an intravesical pretzel. It's a little tube that has pills lined inside of it with a microfluidic pore drilled into it to allow a constant elution of whatever drug it is. They're looking at gemcitabine and erdafitinib. There's also the Urogen product that's similar to Mitagel for the upper tract. It's a aqueous gel of mitomycin, again, trying to increase the contact time in the bladder. There's other viral oncolytic treatments, cretostimogene, that's been reported at this meeting and other meetings. And then the other very important concept is that all of these treatments are also now being looked earlier before BCG or compared with BCG. And just like we saw with the prostate cancer drugs where they were first approved in the advanced disease or salvage setting and then got approved for upfront therapy, all of these agents are being looked at in earlier disease states. And this is just a quick schematic of all of the trials that are going on. The top box is the phase 2 trials. The bottom is the phase 3 trials, intermediate risk, BCG naive high risk, BCG unresponsive. So this slide will be different a year from now for sure. Now switching gears a little bit to the muscle invasive space. Again, as I showed, these are tumors that invade deeply into the muscle wall of the bladder. These are the patients that we really worry about that are at risk for death from bladder cancer. This is clinical stage T2 and higher, diagnosed on TURBT. We will risk stratify them and rule out metastatic disease with imaging. We don't have a molecular imaging for bladder like we do for prostate with PSMA. It's a big area of unmet need. And these patients really should be considered for cystectomy unless they're too old or too sick or refuse cystectomy. So one of the seminal advancements in bladder cancer treatment is the SWOG study reported out 22 years ago. Bart Grossman at MD Anderson was the lead. This looked at neoadjuvant chemotherapy followed by cystectomy compared with cystectomy alone. And this was a little bit of heresy back in the 90s because we know that invasive bladder cancer is a ticking time bomb. So why would we ever delay their potentially curative surgery to give them chemotherapy? And it's because it helps improve survival. So even though it took a long time to really get adopted or embraced, it is absolutely ensconced and firmly part of the guidelines in patients that are appropriate for chemo with muscle-invasive disease that are scheduled for cystectomy. We really should be thinking about giving them neoadjuvant chemotherapy first. This looked at MVAC, old-fashioned MVAC, without growth factor support, very toxic. But there's been several combinations after that have been looked at. The other important thing is looking at what their final pathology was after cystectomy. And you can see here that in patients that got preoperative chemo, upwards of 40% of them had no residual disease. There were actually 15% of the non-chemo that did. That sort of indicates that if you do an aggressive TUR, you might actually remove most of the tumor. But the benefit in the survival really seemed to be in the patients that it did achieve a good pathological response. This was followed on by several other neoadjuvant trials looking at MVAC and dose-dense MVAC and gemcitabine cisplatin, all cisplatin combination chemo regimens. We were a part of a trial together with Fox Chase looking at dose-dense MVAC in the neoadjuvant space. And this was, dose-dense MVAC is an accelerated MVAC. It's given quickly, and so it sort of tempers some of the concern of the delay in getting them to the OR. So this is 3 cycles each 2 weeks, and then followed by surgery. And so the typical time in this trial from starting chemo to surgery was just under 10 weeks, much quicker than typically we would think about. Very similar pathologic response. You can see T0 almost identical, 38%. And also importantly, almost 2/3 of the patients had at least some pathology downstaging. So if they didn't achieve T0, the T0 or T1 or TIS. So why do we want to give chemo to patients that may not need it? If they don't have any tumor left in their bladder, why not just wait till after surgery? And this is a slide that I got from Jeannie Hoffman-Sensitz. She used to be with us at Jefferson in medical oncology. She's now at Hopkins. And this is her analogy. This is what patients look like to her when we send them over. When they're, oops, wrong direction. But anyway, before surgery, the neoadjuvant patients look great, and they limp in after surgery. And she has to try to give them chemo. Certainly, scientifically, it makes sense to hold chemo until you need it. But the other very important aspect of this is that even in patients that really might benefit from chemotherapy, upwards of 1/3 of them just don't respond quick enough and well enough after surgery to get chemotherapy. And then, of course, there's a lack of a phase 3 trial showing the same benefit. So the EAU and ASCO came up with a consensus guideline. Neoadjuvant chemotherapy is recommended for clinical stage 2 or higher bladder cancer prior to cystectomy. And then actually, I need to update this, or they need to update this. We'll talk about how first-line therapy for metastatic bladder cancer has really changed very dramatically. Looking at several different studies, the pathologic downstaging very consistently in the 20 to 30% range, reassuring that it's not a single study. And if you look at the different categories of patients, it really does seem like the majority of benefit are in the patients that get pathologic downstaging in terms of their overall survival. But still, we have lots of opportunity here because only 30+%, 40% of patients get a good T0 rate. So now we have the concept, and this is also new since last year, the perioperative sandwich therapy. And this is not from Subway, but this is looking at giving neoadjuvant cisplatin-based combination chemotherapy together with perioperative durvalumab, which is another immune checkpoint inhibitor. The Niagara trial was a phase 3 randomized trial of patients with muscle-invasive bladder cancer scheduled for cystectomy, over 1,000 patients, 1-to-1 randomization, looking at neoadjuvant gemcitabine cisplatin, not MVAC, but felt to be equipoise and easier to give, with durvalumab, followed by adjuvant durvalumab for 8 cycles post-op. The primary endpoint was event-free survival and secondary of overall survival. And the end result is that this sandwich therapy, pre-op chemo immunotherapy followed by post-op immunotherapy, significantly improved event-free survival. And you can see here the Kaplan-Meier curves, hazard ratio of 0.68, really a dramatic improvement in these patients. What other options have been looked at? The PURE-01 study looked at preoperative pembrolizumab in patients that could not tolerate cisplatin-based multi-agent chemotherapy. This is 3 cycles of pembro preoperatively followed by cystectomy, the PURE-01 study. Again, it's amazing how consistent the pathologic complete response rate in this trial was 39%, and this did also show benefit. So this is another option in patients that may not tolerate chemotherapy pre-op. So what do we do after surgery and we get a bad path report? We do get good path reports, 40% of the time, but there definitely are some patients where we don't get as much of a response as we want. And the patients that have residual invasive bladder cancer after cystectomy, after neoadjuvant chemotherapy, are at the highest risk of recurrence and death. And we really do pay attention to what they got pre-op to give an idea of their risk post-op. So if they didn't get any neoadjuvant chemotherapy pre-op, it's not a big stretch or a surprise that they would still have T2 or muscle-invasive disease post-op. But if they did get neoadjuvant chemotherapy and they have any invasive disease or node positive, those are the real red flags. And this is built right into the NCCN guidelines that if sandwich therapy, I keep hitting the wrong button. Sandwich therapy is given, you want to continue the durvalumab post-op. If no cisplatin neoadjuvant chemotherapy given and they're T3 plus or node positive, we should think about either adjuvant cisplatin chemo if they can tolerate it, or adjuvant checkpoint inhibition, most commonly nivolumab. If they got neoadjuvant chemotherapy and still had muscle-invasive disease or node positive, again, we should give adjuvant therapy. So here you can see this is also baked right into the NCCN guidelines. This box over here is new, the perioperative sandwich therapy. We may not be done with systemic therapy after surgery, unfortunately. So now moving forward to metastatic urothelial carcinoma. PD-1 inhibition and immune checkpoint inhibition has been a revolution in all of solid tumor oncology. It's working with antibodies to try to interrupt the interaction of PD-1 with PD-L1 between the T cells and the tumor cells. I definitely don't pretend to understand the mechanisms, but my very simplistic understanding is that we're stepping off the brake and we're revving up the gas of the immune system, trying to rev up our immune system to be vigilant against the tumor. Here you can see CTLA-4 is another important regulator that is in the immune therapy armamentarium. And this is built right into first-line therapy. This is the NCCN guideline from last year. And you can see the preferred regimen, if they're eligible for cisplatin, would be to give gemcitabine, cisplatin, or MVAC. But it's amazing how things change, because right now we have a new agent that has knocked chemotherapy off the mountain, and that's enfortumab vedotin together with pembrolizumab, or EVP. And so what is this? This was reported a little over a year ago. This is the EV302 trial. And enfortumab is an antibody-drug conjugate directed against Nectin-4. Nectin-4 is a cell surface molecule overexpressed in a variety of solid tumors, including urothelial carcinoma. It's given together with immune checkpoint inhibition with pembrolizumab. This was a phase 3 randomized trial, superiority design, comparing EVP to gemcitabine cisplatin, almost 900 patients, and maybe not surprisingly, but it certainly caused a big splash. EVP trounced them in the study with a significant dramatic improvement in progression-free survival and overall survival. So this has now supplanted cisplatin-based chemotherapy as the first line for metastatic or locally advanced bladder cancer. Dramatic separation of the curves, really hazard ratio of 0.45, so it's a 55% improvement in survival. So we have the treatment landscape, and my residency encompassed this little area. So we had cisplatin, then gemcitabine, nothing, and now we have an explosion of agents. It just keeps coming. It's really quite a time in bladder cancer. This is a diagram, again, that I had to adjust because the first decision tree used to be whether they're eligible or ineligible for chemo, but above everything, we now have enfortumab vedotin with pembrolizumab. Unfortunately, if they fail this, then we get into the same decision tree on whether they can get cisplatin combination chemotherapy. So the definition of cisplatin eligibility is not necessarily straightforward. Most commonly, it's because of concerns of renal insufficiency or chronic kidney disease. It's a little cruel twist of fate that the most effective agent in bladder cancer requires good kidney function, but certainly congestive heart failure, ototoxicity, pre-existing neuropathy, poor performance status, all go into the mix, and our medical oncologists typically would shy away from cisplatin if they have any of these. The typical creatinine clearance of 60, they will push sometimes down to 50, especially with split dosing. If you look at an aging population, patients in their late 60s, 70s, almost half of these patients will have one of these criteria to be cisplatin ineligible. Another newer concept for bladder cancer is maintenance therapy with immune checkpoint inhibition, and this was shown by the Javelin Bladder 100 trial. These are patients with metastatic or locally advanced urothelial carcinoma that had a response to chemotherapy. Didn't have to have a complete response, but they had at least stable disease or partial response. They were randomized to avelumab, another immune checkpoint inhibitor, versus best supportive care to see if after chemo, if giving them immune checkpoint inhibition would be beneficial. This also showed benefit with an improvement in the median overall survival when they got avelumab adjuvantly. So this is now baked into the guidelines as well. Along the same lines, Checkmate 901, this looked at gemcitabine cisplatin with nivolumab. This was a phase 3 trial of an advanced urothelial cancer in the first line. This looked at GC, or gemcitabine cisplatin, with concurrent nivolumab followed by adjuvant nivolumab maintenance versus GC alone. Large trial, 600 patients. And the addition of immune checkpoint inhibition to gemcitabine cisplatin, very much similar to the sandwich therapy that we mentioned with GC and durvalumab, showed a significant improvement in overall survival from 18 months to 21 months. So now we're really getting down the disease path, second, third line, and beyond. What are we going to offer these patients? We've thought about enfortumab pembrolizumab, EVP. We've thought about cisplatin-based chemo. We've thought about immune checkpoint inhibition. Now we're really starting to run out of the options, and now we're getting into biomarker-driven therapy. And the two big biomarker therapies are erdafitinib and trastuzumab. So erdafitinib, or Balversa, is an oral FGFR inhibitor, so fibroblast growth factor inhibitor. They need to have evidence of alterations of FGFR2 or 3, which are only typically present in about 20% of patients, but if they do have these alterations, erdafitinib does show activity with an overall response rate of 32%. Also brand new is trastuzumab. This is in HER2 brand name. This is another antibody drug conjugate targeting the HER2, or human epidermal growth factor receptor 2, most prominently present in breast cancer. But this was a tumor agnostic approval. Any solid tumor that expresses HER2 is eligible for trastuzumab. Again, in bladder cancer, the expression disappointing, much wider spread of different studies from 7 to 35%, but an overall response rate in, again, second, third line patients of 51%. So we still have a lot to do. You can see here 100% of patients with metastatic or locally advanced bladder cancer. Unfortunately, only about half of them even get first-line therapy for a variety of reasons: access, frailty, age, comorbidities. Only about 17% get second line, only about 6% get third line. So there's still tremendous opportunity in this space with multiple different tumor targets on either tumor or the immune system cascade. There's multiple clinical trials still going on, looking at combinations. It certainly seems like the combination approach is going to be the best rather than the sequential approach. And then very briefly, I'll talk a little bit about upper tract urothelial carcinoma. This is considered a rare tumor. It's a urothelial tumor arising outside of the bladder, and either in the urothelial lining of the ureter or the collecting part, the funnel part of the kidney, the renal pelvis. Most of our expectations, treatment options, expectations of efficacy are extrapolated from bladder cancer because it is still the urothelium, although that has been questioned and whether that's legitimate. Jeannie Hoffman-Sensitz, I give her a lot of credit. She's really devoted a lot of time and energy to upper tract urothelial carcinoma. It's only about 5% of all urothelial carcinomas. 90 to 95% are in the bladder. She, through the ECOG cooperative group, she did a phase 2 single-arm trial of dose-dense neoadjuvant chemotherapy, very analogous to bladder cancer. A little lower pathologic complete response rate than we see in bladder, but not surprising because we're not really able to do bulk endoscopically as well as we can with a TURBT, but did see significant downstaging to T1 or less in 60% of patients. There also was the POUT study. This is another adjuvant or post-op gemcitabine cisplatin or gemcitabine carboplatin trial that did show significantly improved disease-free survival. Again, this is tough to give adjuvantly with a solitary kidney, but if they do have adequate function, should be considered. And Jeannie now has a follow-on ECOG trial, the ECOG 8192, similar to what we've talked about earlier, looking at neoadjuvant dose-dense MVAC in combination with durvalumab to see if that will boost the pathologic CR rate. And I thank you.
So I'm the lucky one, unlike with prostate cancer and bladder cancer, where there have been significant changes and discoveries over the last year. Renal cell carcinoma, although in the last 5 years there's been a lot of advancement, certainly over the last year when you look at the NCCN guidelines, which I will show you a little bit later, there has not been much. I do have no disclosures. Okay, so let's start with some epidemiology. Renal cell carcinoma accounts for about 2 to 3% of all cancer deaths. Median age of diagnosis is a little bit older at 65. Age of death is 70. The rate has increased about 2% per year over the past 65 years. 90% of the tumors are renal cell carcinoma, with the majority of those being clear cell. And as the stage goes up, the survival goes down. There are some factors that can actually predispose to renal cell carcinoma: smoking and obesity. There is also hereditary renal cell carcinomas, such as with von Hippel-Lindau. And at this point, surgical resection or ablation remain the only effective therapies for clinically localized renal cell carcinoma. Looking at the 2024 kidney cancer statistics, for both men and women, kidney cancer, which is lumped together with cancers of the renal pelvis, are in the top 10 as far as incidence goes. However, when looking at mortality, they both fall off the spectrum, so meaning that these cancers are not as lethal as what we see with other GU malignancies or other malignancies, period. This slide is a little bit difficult, but what it's showing is the age at presentation and the years of how long the patients will actually live with disease. And again, it's kind of highlighting that the fact that you're picking this up kind of in the 5th or 6th decade of life, and a lot of these patients are expected to live several years with their disease. As I mentioned, it's a heterogeneous disease. Typically, we try to divide it into two categories: clear cell and non-clear cell. Clear cell, as I mentioned, is the most common type. It's also the most lethal type. Papillary renal cell carcinoma, which used to be divided into type 1 and type 2, has now been lumped into just papillary renal cell carcinoma by our pathologists. Chromophobe renal cell carcinoma is a little bit less common and a little bit less lethal. And then there are some very lethal subtypes, as well as some benign subtypes, which comprise about 5% of all tumors. This is what it looks like under the microscope. Clear cell has that really classic clear cytoplasm. Again, incidence is about 75 to 85% of all tumor types or of all renal cell carcinoma. The associated mutation with that is VHL, or von Hippel-Lindau. Papillary 1 and 2 are now called papillary renal cell carcinoma. Papillary type 2, which has those eosinophilic cells, is thought to be the more lethal subvariant of papillary renal cell carcinoma. However, as I mentioned before, our pathologists now are just categorizing this into papillary renal cell carcinoma. Under the microscope, although this slide doesn't really show it, under the microscope, it's difficult to divide chromophobe renal cell carcinoma from oncocytoma, and they are both present in patients with Birt-Hogg-Dubé syndrome, although the chromophobe, like I mentioned earlier, is a little bit less of an aggressive variant. Also, as I said earlier, as the stage goes up, the survival goes down, but thankfully, most of the patients who present with renal cell carcinoma actually present with a lower stage of tumor, and then obviously the metastatic disease can be present and classically is thought to be in 25 to 30% of patients who present with renal cell carcinoma. Classically, renal cell carcinoma is thought to be resistant to chemotherapy. There have been several clinical trials over the years that have looked at this, with over 4,000 patients in those trials, and the overall response rate of about only 6%. And those are some of the agents that are thought to have some activity against renal cell carcinoma, although I will say our medical oncologists do not use these at this point. It's even though when you look at this slide, the lines look relatively flat, it's actually not the case. And over the years, we have actually seen improvement in survival for renal cell carcinoma, both the 1-year and 5-year survivals. So although it is resistant to chemotherapy, there is thought to be an immunological response in kidney cancer, and this has been documented by several findings. Spontaneous remissions have been documented, as well as a very robust abscopal effect which means that you get regression of metastases after treatment of the primary tumor. So that has actually been documented especially with clear cell renal cell carcinoma. There is an increased risk of cancer in patients with immunodeficient states or who are on immunosuppression, such as patients who receive transplantation. And their tumors are known to possess a significant number of tumor-infiltrating lymphocytes. Kevin Zarabi is one of our medical oncologists who I asked about how he classifies or how he looks at patients who present with metastatic renal cell carcinoma. And he actually goes through a very logical cascade of how he really classifies these patients. Step one of this is a risk classification. He uses the IMDC risk model. The characteristics or the criteria which are involved in that model are listed below, and the graphs on the table on the side, the graph on the side actually shows that patients with better risk disease or favorable risk disease actually do better from a survival standpoint as opposed to intermediate or poor risk disease. Now, when looking at the IMDC criteria a little bit more closely, and again, looking at the different characteristics involved in it, actually the vast majority of patients who present with metastatic renal cell carcinoma are actually documented as IMDC intermediate or actually high risk. So only about 20% of patients who present with metastatic renal cell carcinoma are actually favorable risk. So the majority of them are actually going to be intermediate or high risk, which will make a difference as far as treatment goes. So the next question that Kevin asks is, should we remove the primary tumor? We thought this was answered several years ago in two separate clinical trials that were reported together in 2004. One was an EORTC trial and one was a SWOG trial. The conclusions of those trials were that cytoreductive nephrectomy did offer a survival advantage and the highest benefit in patients who had a performance status of 0. So the best patients were the most healthy patients. Now, the interesting thing about this is that there were minimal surgical complications in those patients who did receive cytoreductive nephrectomy. And the agent that they used to treat these patients, because it was, these trials were really carried out in the late 90s, was interferon. But the vast majority of the patients who received a cytoreductive nephrectomy actually went on to receive interferon as well. There were some criticisms of this trial or of these reports. They thought that the benefit was very modest, and they thought the accrual period was actually quite long. But again, I think that the key of all of this is that nearly all the patients in these trials received systemic therapy. Now, we know that with cytoreductive nephrectomy, especially patients who are presenting with metastatic renal cell carcinoma, that we are not doing favors to all of them by taking their kidneys out. There are tumor factors and there are patient factors which kind of figure into this. And the problem is that by taking these kidneys out, you actually may limit the receipt of systemic therapy. And as we showed with those two trials before, receiving systemic therapy is actually paramount in these patients. So in the study on the left, those were tumor types, patients with metastatic disease who had sarcomatoid tumors versus non-sarcomatoid tumors actually did more poorly. So it'd be nice to understand possibly by biopsy if these patients had sarcomatoid tumors at presentation, and these may be patients who you would consider systemic therapy with. And then looking at performance status, again, patients who were healthier actually did better. So you want to make sure that if you're considering a cytoreductive nephrectomy, you're going to consider it in a patient with a good performance status. And then came the Carmina and the Surtime trials. This is the Carmina trial, and it was designed as a non-inferiority trial. It was 1-to-1 patients with metastatic clear cell renal cell carcinoma to undergo nephrectomy and then receive sunitinib versus patients who received sunitinib alone. Now, in the ITT populations, patients in the sunitinib alone actually had a longer median overall survival. So again, this is level 1 evidence against what we had already thought, that cytoreductive nephrectomy was better. And it was actually interesting in the nephrectomy sunitinib group, so patients who underwent cytoreductive nephrectomy, almost 7% of the patients actually didn't undergo nephrectomy because their performance status was so bad, but even more so, almost 20% of patients who received a cytoreductive nephrectomy never received systemic therapy. Again, patients who receive systemic therapy who have metastatic renal cell carcinoma are thought to do better. So 20% in this trial didn't do it. And then in the actual sunitinib alone group, almost 20% of the patients actually went on to receive a subsequent nephrectomy, which was also very interesting. This is the SERTIME trial. I think the design was a little bit better in this trial because it kind of mimicked what we're kind of doing in real time. It was immediate cytoreductive nephrectomy followed by Sutent versus treatment with 3 cycles of Sutent, then a cytoreductive nephrectomy. And if the patients didn't progress, then if the patients did not progress on imaging, then they received a cytoreductive nephrectomy and then went on to continued systemic therapy. And in the patients who received systemic therapy up front, they actually did better than the patients who received a cytoreductive nephrectomy up front. And again, it was shown that if patients progressed who received systemic therapy up front, so they progressed on systemic therapy, those are the patients who were thought to need to require additional systemic therapy with different agents. And if you performed a cytoreductive nephrectomy up front, very often these patients would actually not benefit from that because they would be dead before they would get to that point. So, going back to Kevin's algorithm, should we remove the primary tumor? The answer is not necessarily, especially for patients who are poor risk, who have high-risk tumors. It may prevent future systemic therapy or earlier second-line systemic therapy. So looking at cytoreductive nephrectomy now in 2025, it improves survival only if systemic therapy is delivered. Not all patients who undergo cytoreductive nephrectomy receive systemic therapy, and not all patients who undergo cytoreductive nephrectomy require systemic therapy. And I think that the Carmina and SERTIME trials certainly have changed how we look at cytoreductive nephrectomy. And when you look at the NCCN guidelines, it also says that you should only consider cytoreductive nephrectomy in patients who have good performance status and in patients who have non-sarcomatoid or lower risk tumors. So finally, do we need to start systemic therapy immediately? And the answer to this is not necessarily, and this is a model that I see some of our medical oncologists using at Jefferson at this point. So patients who are relatively healthy, who have low volume metastatic disease, very often they will place them on active surveillance and only start systemic therapy once they have progressed on active surveillance. This was looked at in the phase 2 trial, which I just showed, and it demonstrated that patients who were placed on active surveillance versus patients who went on treatment first actually did better. So the answer to, do we need to start systemic therapy immediately? The answer is maybe not. The opportunity for quality of life off treatment with careful and close follow-up, and really only start systemic therapy in this patient population once they progress. Okay, so when looking, and here's some more timelines, at the kind of the stone age of treatment of metastatic renal cell carcinoma, the cytokine era, really all that was available was interferon and IL-2. And I remember giving IL-2 when I was a resident to these patients, and man, they did very, very poorly. Starting in 2005, that was the targeted therapy era. So the targeted therapies were based on the discovery of VEGF, and the tumorigenesis was discovered to be dependent on mutation to the VHL tumor suppressor gene, which was present in more than 90% of patients with clear cell renal cell carcinoma. When you have a mutation of the VHL gene, it leads to an aberrant accumulation of HIF, and what this does is it acts as a transcription factor for agents which drive tumorigenesis and angiogenesis, including VEGF. Now, it has also been well documented that patients who have clear cell renal cell carcinoma that are VEGF positive from a survival standpoint do worse than patients who are VEGF negative. So as a result, there were many agents that were developed to block various pathways of VEGF accumulation and HIF accumulation, and these were considered tyrosine kinase inhibitors. And this was the targeted treatment era for metastatic renal cell carcinoma. This is what really the workhorse of this era. It was sunitinib or Sutent. This is the trial that led to its approval. It was published back in 2007. Sutent was randomized 1-to-1 against interferon alpha, and significantly outperformed it in patients with metastatic disease. However, one of the problems seen with Sutent versus interferon alpha was the actual tolerability, and this is just as painful as it actually looks. It is the dreaded hand-foot syndrome in patients who are receiving targeted therapies for metastatic renal cell carcinoma, and this often leads to discontinuation of drug. Published in the same journal as the sunitinib trial was a sorafenib trial. Sorafenib was randomized against placebo, but it also outperformed it and led to its approval for the treatment of metastatic clear cell renal cell carcinoma. And these are several agents that were also approved, but the targeted therapies, again, because we didn't have much before that, they were pretty much randomized against what was thought to be a very inferior comparator, which was interferon. However, tolerability was certainly an issue, and as a result, pazopanib was developed, which was thought to be a targeted agent which would be better tolerated than the classic Sutent or sorafenib. This is a compares trial comparing first line, so patients who are untreated with metastatic clear cell renal cell carcinoma, non-inferiority study, patients randomized 1-to-1 to receive pazopanib versus sunitinib. And the lines, the progression-free survival and the overall survival lines kind of overlap each other. So it was a positive study showing that it was non-inferior to sunitinib from a cancer control standpoint. However, looking at the adverse events, so at the tolerability, certainly pazopanib was favorable versus sunitinib. In most of the documented side effects, it actually was favored on this, as documented on this forest plot. So as a result, I do see our medical oncologists, when they are using targeted agents now, they often go to pazopanib just because of its tolerability over sunitinib. However, it was short-lived, the targeted era phase, because of the tolerability, and some of the results were not as beneficial as what you would hope. And with the advent of some of the checkpoint inhibitors and some of the more advanced multi-kinase inhibitors, we are now in the golden age of metastatic renal cell carcinoma. In the golden age, I do include a multi-kinase inhibitor called cabozantinib. The pathways that it inhibits includes the classic VEGF pathway, but other pathways that also lead to tumorigenesis and angiogenesis. This is the Cabozantinib trial, which looked at first-line cabozantinib, so patients who were untreated for metastatic clear cell renal cell carcinoma, randomized against sunitinib, and these patients were poor or intermediate risk patients. It was a phase 2 trial. And actually, the cabozantinib certainly outperformed sunitinib, as documented in these Kaplan-Meier curves, with a response rate of 46% versus 8%, and the tolerability about the same, with the adverse events almost exactly the same as 67 versus 68%. And it was the first study to show a targeted agent with superiority over sunitinib. And at that time, cabozantinib was approved for first-line metastatic renal cell carcinoma, particularly in patients who were poor or intermediate risk by IMDC criteria. However, also at this time, checkpoint inhibitors were being looked at for patients with metastatic renal cell carcinoma. This was a New England Journal of Medicine article published back in 2015, looking at heavily pretreated patients who went on to receive nivolumab randomized against everolimus, and everolimus was one of the more popular targeted agents which was being used at this time. As documented by this curve, the nivolumab certainly outpaced the everolimus with a hazard ratio of 0.73. So, but even more so impressive was the tolerability. The adverse events seen with the everolimus, the grade 3 or 4 adverse events were just 19% versus 37% in patients who received everolimus. So the nivolumab not only showed a survival benefit in second line and beyond patients with metastatic renal cell carcinoma, but also showed an improvement in tolerability, which kind of showed that the monotherapy targeted agent era was coming to an end. This was another study now looking at combination therapy. This was with 2 checkpoint inhibitors, the more conventional PD-1, PD-L1 inhibitor, nivolumab, with an anti-CTLA-4 inhibitor, which is also one of the checkpoint inhibitors, which is ipilimumab, or ipi-nivo, as we like to call it. This was a phase 3 study in patients with untreated advanced metastatic clear cell renal cell carcinoma, and these patients were randomized against sunitinib. And with the combination checkpoint inhibition, you saw a significant benefit in progression-free and overall survival, and the hazard ratios and everything are reported on the actual right. Also, as impressive, there was a complete response rate, so pathologic CRs, which you almost never see with metastatic renal cell carcinoma, of 9% in the ipi-nivo group versus just 1% in the sutent group. And even with the combination, because combination therapy versus single agent therapy, because they were both checkpoint inhibitors, you were seeing an better tolerability with grade 3 and 4 adverse events just at 46% versus 63% in patients who received sutent. And it was based on this that ipi-nivo was approved for first-line treatment in patients with intermediate or poor risk metastatic renal cell carcinoma. However, also in this study, interestingly enough, when they substratified the groups by IMTC risk stratification for favorable risk disease, actually sutent did show better numbers or better survival. And when the NCCN guidelines were updated based on this trial, they actually divided patients by IMDC risk classification, favorable and poor or intermediate risk, and for the favorable group, sutent was listed, and for the poor and intermediate risk, actually ipi-nivo was listed. But now we see that there are really 2 classes of agents that have activity against metastatic clear cell renal cell carcinoma. The next logical question would be, what happens when you actually combine these? So, and that is really where we are at this point, where you are combining the VEGF targeted therapy, the tyrosine kinase inhibitors, and the immunotherapy, and most of the regimens that we are seeing right now are the combination regimens. This was the first one that was published. This is pembroexitinib versus sunitinib for patients with advanced renal cell carcinoma. This was a phase 3 trial, patients randomized 1-to-1 with the primary endpoints of overall survival and progression-free survival, and this was first-line treatment. So again, you're seeing a significant separation of the curves from early on and persistent all the way through in progression-free and overall survival. And the interesting thing about this study is that the benefit of pembrolizumab and axitinib, so the combination therapy, was observed across all IMDC risk groups and regardless of PD-L1 expression. So there was a time when we would send these patients to our medical oncologists and have to get PD-L1 expression to show that these tumors actually express PD-L1 before we gave them checkpoint inhibition, knowing that if there was a higher percentage of PD-L1 expression, that those patients actually did better. However, we do now realize that regardless of PD-L1 expression, these checkpoint inhibitors actually will work. Now, as far as tolerability goes, the numbers are actually a little bit closer because now you're combining with the checkpoint inhibitor a targeted agent, so you're seeing similar adverse events, grade 3 and 4, as you're seeing in the comparator group, which was with sunitinib. However, based on these findings, the FDA did approve pembrolizumab and axitinib for first-line advanced clear cell renal cell carcinoma. The CheckMate 9ER trial looked at another combination regimen of nivolumab plus cabozantinib, which again is that multi-kinase inhibitor. Again, the comparator here was sunitinib. Also, patients were untreated, so this was a first-line study. Patients randomized 1-to-1 with the primary endpoints of progression-free survival. The combination, as with the prior study, the combination regimen certainly outpaced Sutent, and again across all IMDC risk groups, and regardless of PD-L1 expression. So based on this trial in 2021, the FDA approved the combination of nivolumab and cabozantinib as the first-line treatment for patients with advanced renal cell carcinoma, again across all IMDC risk groups. So the advantage of Sutent in the favorable IMDC risk group started to kind of fall off, and the NCCN guidelines were changed to actually update that as well. This is the relative new kid on the block, the lenvatinib plus pembrolizumab. This was compared against everolimus, again for patients with advanced renal cell carcinoma. Now, this was an actually very interesting trial. Patients were randomized 1-to-1. So lenvatinib is another multi-kinase inhibitor, just like cabozantinib. So the first arm was lenvatinib plus pembrolizumab. The second arm, lenvatinib plus everolimus. And finally, the last one was the classic comparator of sunitinib with the primary endpoint of progression-free survival and the secondary endpoint of overall survival. Now, when looking at the results of this, again, patients randomized 1-to-1. The progression-free survival was significantly longer in the pembro-lenvatinib group than the sunitinib group. So comparing those two arms, you saw a benefit in the combination combination arm. Looking at the lenvatinib plus the everolimus group versus sunitinib, you also saw a benefit. And so these benefits compared to sunitinib were demonstrated across all evaluated subgroups, including all IMDC subgroups. Now, when looking at the lenvatinib pembro group versus the lenvatinib everolimus, so two targeted therapy groups, you actually saw benefit of the combination multi-kinase inhibitor along with the immunotherapy agent. So based on all of this, the FDA did approve the combination of lenvatinib and pembrolizumab as first-line treatment for patients with advanced renal cell carcinoma, again, the clear cell variant. So looking at our NCCN guidelines, this is from March of 25. Again, patients are stratified in their IMDC risk classification as favorable versus poor or intermediate. Certainly, and all of the trials that I just mentioned all of the combinations of checkpoint inhibition along with tyrosine kinase inhibitors. They're all listed here, along with ipi-nivo for the favorable group, and sunitinib has been pushed over for other recommended regimens. For the poor and intermediate risk group, again, now you have the combination regimens, but cabozantinib is also recommended as a preferred regimen as a monotherapy. Another way of looking at this, this is really looking at second line and beyond. Now they are stratifying it by patients who are immunotherapy naive versus patients who had prior immunotherapy. So in the immunotherapy naive groups, again, the regimens that I listed, all the immunotherapy involved regimens are listed here. However, in patients who had prior IO therapy, now it's getting a little bit less populated, and some of the targeted agents are recommended in these categories. And this is for non-clear cell. So one thing that you've probably noticed is that most of my talk has been focused on clear cell renal cell carcinoma. However, in the non-clear cell category, there really isn't much, and there's certainly a lot of availability for clinical trials looking at these particular sets of patients. So patients with papillary, chromophobe, who have just aggressive disease, and what do you do with these patients? And even now, we are still at an area where we don't really have an answer for this. So you can see that really the preferred regimen, number one listed, is clinical trial for these patients with cabozantinib monotherapy and some other targeted agents listed. The other thing that we do not have with this are head-to-head comparisons between some of these combination regimens. Again, most of them have been compared against sunitinib, and I do think that there is certainly room for further studies looking at possible superiority of one of the combination regimens over the other. I'm going to spend a little bit talking about localized disease and adjuvant therapy. So this was an area of very active research. However, we knew that with locally advanced disease, was there a benefit to adding something to prevent recurrence, especially in patients who were thought to be at risk for recurrence? So these are the studies that actually looked at all of this, and unfortunately, the vast majority of these were negative studies. Most of these studies actually involve TKIs, Sutent, everolimus. We at Jefferson were involved in the majority of these studies. The only one that showed some benefit was the S-TRAC study, which looked at Sutent. But the problem with this is that it did not show a benefit in overall survival. And the FDA did approve Sutent at the time for adjuvant therapy in patients with locally advanced disease. However, our medical oncologists, partly because of the tolerability and partly because of the fact that it didn't prove a benefit in overall survival, were hesitant to use this in these patients. And then came this Keynote trial, which looked at adjuvant pembrolizumab after nephrectomy in patients with locally advanced metastatic renal cell carcinoma. It was a 1-to-1 randomization, pembrolizumab versus placebo. You can see what their definition of locally advanced was down there, with the primary endpoint being disease-free survival. And pembrolizumab did outperform placebo in all of these patients, and as a result, it was thought to be a positive trial. You can see the forest plot below, looking at all the subgroups and the fact that pembrolizumab was actually shown to be beneficial in all of those. In these trials, there were 51 deaths, 18 in the pembrolizumab group and 33 in the placebo group, and the median survival was not reached really in either group, but 32% of the patients who received pembrolizumab and 18% of those who received placebo had an adverse event. And these are the curves looking at all of the different endpoints, and in all of them, you really saw a benefit of pembrolizumab. And when the results were updated at GU ASCO in 2024, the perceived benefit actually persisted, and as a result of this, the FDA did approve pembrolizumab as a adjuvant treatment in patients with locally advanced renal cell carcinoma who had their disease completely resected. So looking at the NCCN guidelines for patients with locally advanced tumors, actually, this is really hot off the presses. Sutent, which used to be on this along with pembrolizumab, now has completely fallen off, and pembrolizumab is the only approved agent for adjuvant therapy in patients with advanced, locally advanced clear cell renal cell carcinoma that has been completely resected. All right, so that is it. Thank you very much for your time. We can go ahead and take questions.
Great presentations, everyone. Thanks so much, and big fan of your book as well. So thank you for that. Just a question about credentialing. So what is your process for credentialing urologists to be prescribing systemic therapies?
So I think that's a very local sort of process. Academic centers have their own sort of pathways and workflows. I think LUGPA has really figured out how to do this better than probably the academics have. From a licensing standpoint, I don't know if there's any specific credentialing needed because anyone can write for, especially the oral agents. I think it's more of a comfort level in your comfort in managing sort of non-urologic issues that come up, especially with the immune checkpoint inhibitors, where it's typically immunologic side effects. So I don't know if there's any explicit sort of answer to that. I think it's very situation. So at our institution, we have in the past for the advanced prostate cancer drugs on a small subset. It's kind of ironic that a lot of the trials that led to approval were run through urology, and then when they got approved, Medonc took it over. That happened with Sapula-Cel-T, it happened with abiraterone, it happened with enzalutamide. Those were all run through our office. And then there's the other, of course, billing aspects of that. My current environment, we're not hospital-based, so we don't enjoy 340B pricing advantage, whereas Medonc does, so the administration doesn't want me to do it. Again, I think everyone's in, but it's certainly not wrong at all for motivated and informed urologists to handle this.
And I think that especially with the from a more practical standpoint, looking at some of the side effects that we see with these medications, a lot of urologists just don't have the knowledge base or the time or want to take the effort to actually treat them, especially with the checkpoint inhibitors. They're so bizarre, some of the side effects that these patients get, but the problem is that some of those side effects can actually be lethal. So, and just as I'd mentioned, a lot of the LUGPAs who are actually administering these medications, they actually have a very broad infrastructure to actually support these patients, to identify these side effects, and to actually treat these side effects. So I think if you are considering using these medications, you have to consider the whole picture. There's obviously the financial, but you have to consider the practical standpoint of, how are you going to deal with these side effects? How are you going to manage these patients? And are you actually doing the right thing? So I think that is certainly a very controversial topic. It's something that comes up quite often. I didn't see any questions on the chat.
There's one rather lengthy one that I'm going to respond to electronically.
Okay, we'll do that as well. All right.
Thanks so much.
That is it. Thank you very much.